Good morning. My name is Martha Montag-Brown. I am privileged to be a board member of Myotonic, and I'm delighted to welcome you to our next session entitled Exercise, Nutrition, and Speech. Our speakers are Katy Eichinger. Did I pronounce that correctly? Oh, good. Katy Eichinger, Leslie Vnenchak, and Robin Meyers. Dr. Eichinger, who we're going to hear from first, is a physical therapist and assistant professor at the University of Rochester, where she's involved in clinical care of individuals with adult and pediatric neuromuscular conditions. She's part of the neuromuscular research team and is involved with natural history studies and other clinical trials involving patients with myotonic dystrophy and other neuromuscular diseases. Leslie Vnenchak is a speech and language pathologist, has worked at the University of Pennsylvania Health System since 2006, providing speech, language, and swallowing services in the Penn Comprehensive ALS Center, Comprehensive Outpatient Parkinson's Evaluation Clinic, and Deep Brain Stimulation Clinic. In addition to her clinical work, she assists with aphasia research at the University of Pennsylvania's Laboratory for Cognitive and Neural Stimulation. And Robin Meyers has been a registered dietitian for over 30 years and has worked with children with special healthcare needs, specifically children with neuromuscular disorders. Most recently, she's been at the Children's Hospital of Philadelphia. She's written several articles and book chapters about nutrition for children with neurological neuromuscular disorders. Please join me in welcoming our speakers this morning.
Thank you. So thank you all. Is this on? Can everyone hear me about that? Good? Okay, so thank you all for coming today. I really love this conference. It has a great time for me, both professionally and personally, as I get to see people, and I see lots of people out there that I know and get to meet new individuals as well. And so I'm really excited for this session. Exercise as a physical therapist is something I'm very passionate about, and just the health and wellness of individuals with myotonic dystrophy is certainly something that I really enjoy thinking about and working with individuals on. So let's see. I don't have slides in front of me. I have my paper copy, so just bear with me, and if I start talking to my slides, let me know. There we go. So just to get us started, I would just like to reflect on the goals of physical therapy and exercise. Why are these things important, and why do we want to think about them? So really the goals of physical therapy and exercise in a chronic progressive condition is really to promote optimal health and wellness, to prevent or delay secondary complications, to maximize functional abilities so that people can do the things that they need to do every day, to improve and increase participation, so that's the things that you're getting out and doing things in society that you want to be doing, and then certainly the ultimate goal is to really improve and maintain quality of life. So the first goal, promoting health and optimal health and wellness. Wellness is a bit of a buzzword these days, and I just wanted to take a minute to differentiate between the two terms. And really, so health is a state of complete physical, mental, and social well-being, and not just merely the absence of disease or infirmity. And that was a definition established by the World Health Organization back in 1948, so it's been around for quite a while. And then wellness takes it a step further and really talks about it being an active process in which people become aware of their choices towards a more successful existence. And so that means that, on a day-to-day basis, we all make gazillion of choices every day, and many of them are involved in our overall health and wellness. And so it's just saying you're making those decisions towards a more successful existence. And none of us are perfect, but I think if we all strive, towards that, that's good for all of us. So we know in myotonic dystrophy that the musculoskeletal involvement results in a progressive decline in strength. We also know, and there's been a fair amount of literature even more recently, that aging and inactivity also result in a loss of muscle strength. So physical activity and exercise are really essential in minimizing the strength loss due to inactivity and disuse, and therefore what allows an individual to maximize their functional abilities, using the most amount of strength that they can. So in 2018, so just last year, the Center of Disease Control, or the CDC, updated their physical activity guidelines. And these were originally written in 2008. And they really didn't make too many changes that are essential to know for this talk. So the guidelines are really that individuals participate in aerobic training at a moderate intensity for 2 hours and 30 minutes a week. And so that would be 5 days of 30 minutes if you want to break it up. They make comments that you can do 75 minutes of more vigorous exercise and things like that. So you can kind of create your own formula of what that 2 hours and 30 minutes looks like. They also recommend that people participate in resistance exercises involving all the major muscle groups 2 to 3 times a week. And when they're talking about moderate intensity, and this is important in thinking about muscle disease, moderate intensity is a level of intensity that when you're doing a cardiovascular exercise or something that's getting your heart rate and respiratory rate up, that it raises, those things raise, but they raise to a level that you're still able to carry on a conversation, but you're not able to sing. So if you think about kind of those times where you get breathless, that you can still carry on your conversation, that's really moderate intensity. When it gets more than that, you're moving into more a higher level intensity. When they talk about moderate intensity for strength training, that's lifting or resistance training. That's lifting a weight or using some form of resistance and doing repetitions. And when you talk about moderate intensity, that's doing 10 to 12 repetitions. Is considered moderate intensity exercise. And you should be tired at that 12th repetition for it to be beneficial. So some examples of cardiovascular activity are brisk walking, you can do water aerobics, bicycling, ballroom dancing, and gardening. I think probably the most important thing, and we'll talk about this in a little bit, is finding something that you enjoy, because that's key to carrying out long term. So then we also need to talk about people who may not be able to meet the regular guidelines. And so individuals that have more involvement of their disease and may not be able to do that, they still make a recommendation, and that is really that people should follow the adult guidelines, but if it's not possible, that people should be as physically active as their abilities allow, and really to avoid inactivity. And that's really important. We've learned a lot about the amount of time that people spend sitting and how it relates to mortality, morbidity, and decline in functional abilities. So there are lots of known benefits of physical activity and exercise. It helps control weight, reduces your risk of cardiovascular disease, reduces risk for type 2 diabetes, reduces risk for cancer, strengthens bones and muscles, improves your mental health and mood, which is certainly a huge benefit for many people. It improves your ability to do daily activities and prevent falls, and it increases your chances of living longer. So lots of known benefits, but there's always this question from people who have muscle disease, well, is it okay for me to exercise? And many years ago, we didn't know, and many individuals were told not to exercise because they had a muscular dystrophy. So over time, the researchers have been able to kind of chip away at this question, and it's really difficult research to do, because certainly as a researcher, the first rule is to never do harm. And so if there's this question of does exercise harm the muscle disease, you have to really kind of move slowly in determining the answers to that. And so there have been several studies, and these are some of the more important ones. And I don't want to get bogged down in the literature, but I definitely did want to kind of address it because I think it's an important point for individuals to understand that I think at this point we're pretty confident that exercise at a moderate intensity level it will not do harm in myotonic dystrophy specifically. So some of the studies is that aerobic training is safe and can improve fitness in people with myotonic dystrophy, and that was a study that was done 100% in individuals with myotonic dystrophy. Then there was a study that looked at a lot of different types of muscle disorders and kind of combined groups and research studies, and they also thought that came to the conclusion that strengthening exercises in combination with aerobic exercise was likely to be effective for people with muscle disorders. And then there was a Cochrane review, which is a very stringent review of literature. So basically the authors would gather the literature that's available, and they have strict inclusion criteria of what those studies are. So there were limited number of studies in this review. But again, this was really to kind of put to bed the discussion of whether or not exercise was safe. And they really came up with the conclusion that moderate intensity exercise doesn't appear to do harm in people with muscle disease. And I guess I should say slowly progressive muscle disease. And I think that's still sometimes where people get confused, especially maybe general providers. There are more rapidly progressive muscle diseases in which this conclusion is not accurate for. So individuals with Duchenne muscular dystrophy, individuals with ALS, those more rapid progressive conditions, they're still a little bit more conservative and concerning. So as far as a little bit more evidence, I thought this was a really interesting study. It's not as stringent as many studies are as far as the gold standard of having a randomized control trial. This was really just a retrospective chart review in which they looked at people in their medical charts over time, and people with a mid-range of a CTG repeat between 100 and 500 engaged in regular exercise, and they could track when these individuals started exercising within their medical record by collecting that information. And what they found is that individuals that were engaged in regular exercise actually showed stronger grip, elbow flexor strength, and knee extensor strength than their sedentary counterparts. And again, like I said, less stringent study, but I think very interesting in the sense that they showed a pretty significant gain. So when we think about pharmaceutical benefits for taking a new agent or a new drug, if we could get 24% gain in strength, people would be ecstatic. So I think that this is really important to think about how much exercise may be able to improve individual strength. And then, again, so when I was preparing for this talk, I was really excited to really closely review the literature. And there's actually, I think I have 3 different studies or papers that have come out in the last 18 months that talk about exercise in individuals with myotonic dystrophy. So this review was done, and it looked at 21 different papers out that have been published. And they looked at all sorts of training programs. So they looked at exercises, the use of neuromuscular electric stimulation, strength training, aerobic training, balance training, and then just kind of multi-intervention. And what they found is that when looking across all these different papers, that exercise and training had a positive effect on patient-reported outcomes, so how patients are doing and how they feel that they're doing with exercise. Improvement in aerobic capacity, and an improvement in muscle endurance. And then there was improvement in function. So some studies would look at how fast people walk or how fast people climb stairs, so looking at changes in function. And in those papers, 4 out of 10 showed an improvement in function. And then there was improvement in strength in 9 out of the 11 studies that were included. So when their conclusions, though, is that, again, there was no adverse effects of exercise, but really we're still lacking evidence to be able to recommend the type, the duration, the frequency, the intensity of exercise to create benefit. And I'm certainly, would love to be able to stand up here and say, well, if you do X, Y, and Z, then you're going to get better. And that really comes down to things need to be a little bit more individualized, and we just don't have that evidence at this point to make those strong recommendations. And then I think, well, maybe I have one more study after this. So this was the Optimistic study that was carried out in the European countries. Very big study in individuals with myotonic dystrophy. You can see they had 128 individuals. And that was just one subgroup. So they had individuals that just had standard of care. They had individuals that just had cognitive behavioral training. And then they had individuals that had cognitive behavioral training plus exercise. And that's really kind of the group that I wanted to talk about. So what they talked about is that the cognitive behavioral therapy, so individuals had 10 to 14 sessions, and what that therapy treated and focused on was challenges that individuals with myotonic dystrophy have, that reduced initiation for increasing physical activity, looking at improving social interactions, sleep-wake patterns, pain, and addressing people's beliefs of fatigue. So the individuals had these one-on-one sessions with a cognitive behavioral therapist, and then they also were involved in an exercise program. And what they found is that those individuals, compared to the other groups, had increased activity, had increased participation, so it goes back to those goals that I was talking about at the beginning, and also had improved fatigue and exercise capacity as measured by a 6-minute walk test, so how far somebody can walk in 6 minutes. So I thought that was, again, just kind of a different way of looking at intervening from an exercise and overall health and wellness standpoint. So then this study, so you can see my bottom line, it was in mice. So we all know that people are different than mice, but I really, this is, I think, the first time that I've seen it in the literature and thought it was really interesting and noteworthy. But what they looked at is they looked at the impact of exercise on the cellular level of mice with myotonic dystrophy. And what they found is that the mice, they were allowed to have their rotowheel in their cage, and they kind of measured how much the mouse used the rotowheel and could correlate the amount of activity in the wheel with their exercise. So, but these mice had increased motor performance, increased strength, and increased endurance in ways that you measure that in mice. And what they did is then looked at the cellular level, and you guys have heard these things as, there was increased mitochondria, so that's our power boost in our muscle, powerhouse, I should say. It also showed that these mice had reduced RNA toxicity and improved mRNA splicing. So again, these are just, we've always talked about exercise and being able to reduce disuse weakness and inactivity-related weakness, but this brings up the question is, does it have some actual effect on the disease process? So certainly, again, a study that was done in mice, and we'll need to keep moving forward, but I thought it was really kind of interesting. So then we talk about physical activity and exercise. So the recommendations from the CDC really talk about physical activity guidelines. So I wanted to talk about how do these two things differentiate. So physical activity in daily life is categorized into your occupational, so things you do at work, sports, conditioning, household or other activities, whereas exercise is actually a subset of physical activity that is planned, it's structured, it's repetitive, and has a final or objective an improvement or at least maintenance of physical fitness. So different types of exercise, so stretching, which is more the range of motion exercises, your strengthening or resistive exercises, aerobic, and that's cardiovascular training, so getting your heart rate up. And then I also added balance training. That's not typically considered, put into the category of types of exercises, but I thought it was something important to bring up with everybody. So when we talk about range of motion, things to think about is that's just moving your limbs in any sort of way, just kind of through the motion of the joint. And people who have difficulty doing that because gravity is this big nasty force, So that might be the case in many people's ankles where they're not able to pick up their feet against gravity. The important thing is to do that. You can do that with gravity minimized, so with your foot up on the bed or on a recliner. And then taking it that next level is really passively doing that, standing up against a wall and actually stretching out the calf muscles to give you that increased range of motion at the ankle joint. What this does is, so again, using the ankle as a model, is the muscles on the front of the leg, so your anterior tibialis muscles are the muscles that often are affected in myotonic dystrophy, and then you have the calf muscles on the back side of the leg, and those muscles are pulling on the leg unevenly because the calf muscle is nice and strong. Even if it does have some weakness related to disease, the calf muscle is a lot stronger than the muscle in the front of the leg. So over time, the range of motion of that ankle can decrease because of the muscle imbalance around the joint. So by stretching the ankle joint and the calf muscles to improve the range of motion at the ankle joint, you can definitely keep that mobility of the joint, which is important for walking. It's important for climbing stairs to be able to have that range of motion in the joint. It also, for some, depending on the joints, sometimes people get muscle pain or get pain around the joints because they're not moving through the range of motion. So it helps to decrease pain around joints at times. Just a time check here. Okay. I'll move a little bit faster here, okay. So aerobic training, so that's your everything that's increasing your heart rate. Cycling, walking, aquatic exercise is great for individuals who have muscle disease and muscle weakness. Dancing, again, I think the most important thing in thinking about activities from an aerobic training standpoint is finding things that you enjoy to do, because that's the important thing from a lifelong activity. Resistive training is anything that is using some sort of resistance, and there's lots of different forms of resistance, so your body weight can be used as resistance. Practicing going from sitting to standing is a great activity to strengthen your leg muscles, using your body weight. Free weights, machines, those elastic resistive bands, soup cans for weaker muscles are great, and again, like I said, aquatic exercise. And we talked about, I said 10 to 12, 12 to 15. Anything above 10 is really kind of at that moderate intensity resistance level. Balance training, so there is some literature on balance training. The challenge of balance training is, again, it's pretty multidimensional and individualized depending on the findings from an assessment. But it can include strength training. It can include range of motion, so you need to have adequate range of motion at your ankles to be able to have good balance. And it needs to be task-oriented, so you can be doing things like standing on one foot, which helps your ability to climb upstairs, because when you're climbing upstairs, it's just basically you're standing on one foot and then standing on the other foot. So it's task-oriented. It also can be multisensory, so we have 3 different systems that contribute to balance, and that's the vision, the vestibular system in the inner ear, and the somatosensory system, or your sensory system in your joints and muscles, in your skin. And so those 3 systems have to work together. The information comes in from the periphery and from your environment and tells you where you are in space. And if those systems aren't gathering information great or together, it can play around with how you respond to balance perturbations. But we can also use that to help strengthen different things. The other challenge for individuals from a balance standpoint with myotonic dystrophy is obviously weakness. So when one of those systems is telling you that you're moving off balance, your brain sends a message back to your muscles to correct your posture. And if the muscles can't kick in strong enough because of weakness, that contributes to challenges with balance. But getting those systems to work better together can really improve balance, and that's been shown in the literature in myotonic dystrophy by a few different people, a few different studies. As far as other formal classes, Tai Chi is great for balance training, and yoga is great from a flexibility as well as also balance training. I think one of the most important things is to minimize the sedentary lifestyle. I said this earlier, that there's a lot of evidence mounting towards the bad effects of sitting and spending a lot of time being sedentary. in a small study that I did actually at the conference here a few years ago, is that in collecting data from many of the participants, is that people with myotonic dystrophy are sitting for over 7.5 hours a day. And unfortunately, a lot of us are probably guilty of this, but it's just something to be mindful of. So if it's challenging and you know you're sitting a lot, is just making a mindful decision to get up and move around, setting an alarm, trying to get yourself to be less sedentary is really important. And again, I know that's challenging for a lot of individuals with myotonic dystrophy just because of some of the other impacts the disease has on people. So I just want to take a minute to talk about motivation and fatigue and how to, again, maximize your activity during the day. And so one way is, certainly from a motivation standpoint, is to plan ahead, and that can be either putting it on your calendar, making a date with a friend. For me, it's putting my exercise clothes on the floor before I go to bed, so that when I get up, they're right there, and it just helps. Any little things. We know that for women, we like to work out with a friend. It's our social time, so certainly partnering up with somebody and going to the pool, and you can both do your own activities once you're there, but just having that accountability of meeting somebody and finding a bit of social interaction with it as well is good. Certainly classes can help with that as well. And sometimes you may have to modify or shorten the class, but still, as you heard in the guidelines, is anything's better than nothing. So we want to do as much as possible. And then just quickly, just as part of this, just wanted to talk about just from a physical therapy intervention standpoint. Certainly we are very involved in making exercise recommendations, but we do it on an individual basis. And like I said, I can't stand up here and tell you exactly what to do. It certainly depends on a lot of different factors, what your interests are, what your abilities are, and making goals. So we definitely are involved in that. We also can help with bracing and orthotic recommendations, as well as assistive devices. And so different braces can be used to help with foot drop. Lots of different ones on the market. Lots of them are over-the-counter, lower profile options. So something, if you're having difficulty with foot drop, these are things to consider. I think the thing that I always think about with individuals with myotonic dystrophy is it doesn't have to be an all or nothing kind of decision. You may need braces for walking longer distances. Braces may be beneficial for walking on uneven surfaces where you may be more apt to catch your toe. So they may be used for those purposes, but around the house or around work, you don't need anything like that. So it's certainly not an all or nothing decision. And then certain assistive devices, one of my favorites is a walking stick. It's probably a little bit more socially acceptable at a younger age to use something like that. A lot of them are collapsible, so that you can just have a collapsible walking stick, like hiking pole that you buy at a sporting goods store. Collapsible, throw it in your bag. If you're walking across a parking lot, you're doing fine, but then you need to start crossing grass, and that's a little bit more challenging. Then you have it right there with you. So I like that, but also you can certainly use canes and walkers to help with balance and mobility. I'm getting the time up. So I have 2 slides left. So my wheelchair's flipping around down there. So just as far as mobility devices, same thing. It's not an all or nothing situation. There may be certain situations that assistive device or mobility device would be beneficial, longer distances for sure. Or uneven terrain. And so there's different, manual wheelchairs, scooters, and power wheelchairs. There you go. So there, I've sped up that last half. Sorry about that. And I think what we're going to do is we'll all present, and we're hoping to have about a half an hour at the end of the talks to be able to answer questions. Okay?
So good morning. My name is Leslie Vnenchak. I'm a speech pathologist working within the Penn Medicine Health System. And I'd like to thank Myotonic for the invitation for being able to speak with all of you today. Let's see how this works. Great. Sorry about that. Okay, so the topic of this discussion is speech and swallowing disorders and myotonic dystrophy. So my objectives for this talk, I would like to explain the role of speech pathology, speech-language pathology, in the evaluation and treatment of speech and swallowing difficulties and myotonic dystrophy. I'd like to discuss the interventions and strategies to improve communication and speech production. And I'd like to discuss the interventions and strategies to improve swallowing. So there's a lot of information to cover. I really wanted to focus on how speech pathology can really help your quality of life and what kind of interventions we can introduce. So we're going to do the best we can within 30 minutes, but again, there'll be more time for questions later. So I want to start off with speech. A very common speech disorder found in myotonic dystrophy is dysarthria. And dysarthria refers to a group of speech disorders characterized by the abnormalities in the strength, speed, range, steadiness, tone, or accuracy of movements required for breathing, phonatory, resonatory, articulatory, or prosodic aspects of speech production. Lots of stuff goes into a motor speech evaluation, and I'll explain this more further. Generally, the reasons why speech difficulties may arise is because a weakness in the musculature, and that's a whole system. There's weaknesses along the system. So how that weakness may present, it may present in the facial muscles, the neck muscles, the tongue muscles, palatal muscles, lip muscles, and also respiratory muscles. So when you have weakness in these areas, myotonic dystrophy may present with reduced loudness, the inability to project your voice the way you want it to or maintain that loudness, speaking in short phrases, difficult to create longer sentences, limited range of pitch. Your voice may have difficulty with increasing, going up or going down. That ability to stretch those vocal cords is sometimes difficult. Hoarse vocal quality, that raspiness. I actually am having some allergies kick in today, so I have my own little raspiness, a part of my voice. Imprecise consonants or distorted vowels, the ability to articulate what you want to say in a precise fashion. Hypernasality. Hypernasality is if there's any weakness in the palatal area, certain speech sounds are difficult to produce. So one I use very commonly would be, think of a B sound, a B. You have to build up intraoral pressure to make that sound. And if there's any weakness, you may have some air escapage coming out through the nose. And slow rate of speech. If there is weakness in those muscles, it's difficult to speak rapidly. So very commonly, a patient will come into the clinic saying, I don't know why I'm here. My neurologist or primary care physician said, go see the speech therapist. Okay, so what does a speech evaluation entail? I think the most important part for me as a clinician is the interview process. I'd like to know what the patient is complaining about, how they feel about their speech production, how they feel like it's affecting their life, or if it's affecting their life. Also, if a loved one is with them, I want to know their views. How's it affecting the relationship? How's it affecting communication? Sometimes they don't always match up. That's why the interview is a wonderful tool. Physical examination, we're going to take a look at the oromusculature, posture, how we're doing with maintaining your musculature throughout, taking a look at the lips and the tongue and how they're coordinating. And the evaluation of speech production, and this ranges for every patient that comes into the clinic. A lot of this is observation during conversation. I may ask someone to read a passage so I can see if there's particular sounds that are disruptive or having difficulty with. There may be some measures that I'll ask, how long can you hold an ah? How long can you hold an S sound? How long can you hold a Z sound? And then after these evaluative tools, we'll talk about the education and the cause of why you're having speech difficulties. It's really important for me as a clinician to know that the patient I'm working with understands why we may embark on this therapy regimen and understand why things aren't working like they want them to or how they should. And then we'll review the recommendations, whether it's continuing on with therapy or maybe just providing education and a check-in in a few months. And then the last thing is I want to create functional goals. So this is a really important thing, I think, across the board with all disciplines. But if the person I'm working with isn't interested in the therapy or they feel like, I'm fine, then that's okay too. That may not be the right time for therapy. So I really want to have the idea from the patient and the loved ones of what they want to participate in therapy for to improve. It could be that someone's doing fine at home talking with family members, but at work, maybe it's getting more difficult. So maybe we'll focus on work-related tasks, or vice versa. So speech therapy. This is extremely personalized to every patient. All right? I really can't think of any plan of care that's exactly the same for any of my patients. But speech therapy may include exercises. Now, the literature is, physical therapy has a lot of literature on exercise. Speech and swallowing muscles are a little different, and we do get a fair amount of workout with speaking and swallowing throughout the day. So right now, from the literature I've been reviewing, we're not really sure if it helps or it may fatigue. So it's on an individual basis. I've had patients come in that we say, all right, let's give this a shot and see if this works. And I may introduce some different exercises to see if we can help the production of speech. Training of speech strategies, I am finding that's really important. Having the opportunity to sit on an ongoing basis with a clinician to problem solve what strategies are going to work for each individual person. Education is huge. Education and counseling. Difficulties with communication is not easy for anyone, not for this patient, but also their loved ones. So education and counseling is also a part of the therapy. And at times I always want a patient to have a backup, right? So if you're fatigued or you feel like you can't get your message across, that you have another way to communicate. And sometimes we will discuss that during our sessions. So strategies to improve speech, and these are general. The goal would be that we introduce these strategies and we figure out which one works for each patient or situation. So repeating the message, word, or phrase. Over-articulate, especially when you have weakness in the facial muscles or the oral muscles. When you over-articulate your sounds, they may come out a little more precise. Increasing your loudness. When you increase loudness, everything seems to work a little bit better. You take a bigger breath, so your lungs have more air to go to your vocal cords. And believe it or not, your articulators start to move better too, so you have better speech production. Changing rate of speech. If you're having difficulties with your rate of speech, sometimes slowing it down may assist the ability to articulate better. Rephrasing. If we all know that look from someone that if you're saying something and they're not understanding you, but yet they don't want to tell you, rephrase the message, right? So maybe if you have a 10-word sentence, try and cut it down, or pick out the key words so you don't have to repeat yourself constantly. Just try and rephrase it a bit. And another one is spelling keywords. We all have those words we get stumped on, right? So, sometimes it's easier just to spell that keyword out. So not only strategies for the speaker, but I want to talk about communication partner tips. And there's a few tips that you can do to help your loved one communicate better. So allowing extra time for communication. Feeling rushed when you're having a difficult time getting speech out, it's not a really great feeling. So making a setting where you have a little extra time or pausing a little bit longer to allow patients with difficulties speaking to get the message out. Watch your communication partner. We not only communicate through words, we communicate through gestures, facial expressions, and body language. So watching your communication partner can be very key to help communication. Tell the speaker you did not understand what was said. And I think this is a big one for me. Always let someone know that you didn't understand the message. Repeat messages to confirm what has been said. try and take the burden off the person that's really working hard to get that message out, and maybe rephrase what you think they heard so they can only have to correct a portion of that message. Discuss how your loved one would like you to assist his or her communication in social situations. This is very important. Not everyone wants, everyone's different. Some people may want assistance with a communication situation. Some may not. They may want a little extra time. So sometimes I will talk about, maybe you put your hand on top of your loved one's hand, and that's a signal that you may want the help, or vice versa, that you don't want the help. And consider having your hearing checked. I can't tell you how many times I have patients come in and, oh, well, he just can't hear me, or she just can't hear me, and he's not wearing his hearing aids. And hearing aids are not perfect. But sometimes we do have some hearing changes that may affect the speaker and the receiver of the message. So that's always something to think about, is having your hearing checked too. So environmental considerations. When I say this, I mean, think about the environment that you're speaking in. One-on-one conversations are always much simpler to communicate with somebody. Position communication partners in close proximity. Talking in far distances is a lot more difficult, and it takes a lot more effort. Decrease or eliminate background noise. Cut the TV, the radio. If you have something important to talk about, have a quiet setting. It's going to be a lot easier to understand that communication. I think that goes for everyone. Well-lit rooms, that goes along with reading facial expressions and body language. It's a lot easier to also read lips in a well-lit room. And having an alternate method of communication, writing things down, gesturing, showing things if the communication, you're having difficulties. And at times, sometimes we talk about alternative means of communication. And we split this up into 3 general categories. Low tech is writing using letterboards. Middle tech would be text-to-speech applications on a smartphone or tablet. It's an app on your phone. You type it in, you press speak, it speaks for you. And high tech would be a speech-generating device that is solely meant for speech purposes. I don't find myself recommending these often in myotonic dystrophy, but it is things out there that if the speech production is difficult, it is there. Middle technology has been really great for a lot of my patients. I wouldn't say it's nice to have a backup, right? So if you have that person that's just not understanding, having something on your phone just to type in and press speak, or even just typing in and showing them what you have to say, it's helped out a lot of my patients in clinic. So now we're going to move on to swallowing impairments. The swallowing impairment, that our medical term is dysphasia or dysphagia. And the definitions we'll just review quickly is defined as a problem involving the oral cavity, pharynx, esophagus, or gastroesophageal junction. And when you have difficulties with dysphagia, it may lead to aspiration. And aspiration is defined as the entry of secretions, food, or any foreign material into the airway that travels below the level of the true vocal folds. Aspiration may occur before, during, or after the pharyngeal phase of swallowing. It can also occur for reflux of gastric contents. So before we move on to the next slide, I do want to do a very quick review of the phases of swallowing. You have your oral phase, where your lips and your tongue, they work together to get food or liquid into a ball and propel it to the back of your throat, which leads us to our pharyngeal phase. Pharyngeal phase, your pharynx contracts, your larynx, your hyoid bone, is this little cartilage up here, gets lifted up and forward. So it gives the airway a little added protection. And that food or liquid goes through the pharynx and it enters into the esophagus. So it's really complicated. This quick thing we take advantage of, and we do all the time. There's a lot of things that happen during swallowing, but that also could go wrong if there's any sensation changes or difficulties with strength. Some very common presentations or complaints of dysphagia myotonic dystrophy: poor oral management of liquids and solids, possibly liquids coming out of the mouth or food or getting stuck within the oral cavity right by the teeth, called pocketing. It's difficult to control that in the mouth. Foods and liquids leaking from the nasal cavity. If there's any kind of palatal weakness, there's a flap in the back of your throat, in your palate. It's called your nasal pharyngeal flap. And that flap closes off the nasal passage because this area is all connected. And sometimes when laughing, it happens to some of us anyway, but if there is some weakness there, we may see some liquids coming through the nose. Complaints of food sticking. Anywhere along this area. You can have food getting stuck up here, here, or here, and depending on what the cause of dysphagia, we figure out where it's getting stuck and why. And coughing during or after a meal. And we all have difficulty swallowing at times. Occasionally is normal. When it becomes during meals all the time, it sometimes could indicate that you're having some more major difficulties with swallowing, and it would be beneficial to see a speech-language pathologist. Or even just mention it to your physician, just to let them know what's going on. Difficulty coordinating breathing and swallowing. It's a complicated process to swallow. So if you are talking, your vocal cords are open, and you're also using your tongues and your lips and everything you need to do to have a good swallow. So coordinating breathing and swallowing is sometimes difficult, and we will see some difficulties if you're drinking rapidly or if you're at a dinner and you're talking a lot and you get that, that little tickle in your throat or coughing. Changes in eating habits. Often I'll hear, I just can't eat that steak anymore. It's too difficult. Or rice gets stuck up here, or sometimes salads. If you see yourself avoiding certain foods, that could be a sign that you're having some difficulties with swallowing that could be helped. Unintentional weight loss or dehydration. You're not trying to lose weight and the weight just keeps going away, or you're having difficult time staying hydrated because of difficulty swallowing liquids. And difficulties with swallowing cold foods or liquids, that spasm feeling in the esophagus, as a lot of my patients describe it as. And sometimes fatigue during meals. So how does a speech pathologist evaluate swallowing function? There's a few ways. If it is identified that a swallowing difficulty is occurring, the physician may recommend that you get a clinical swallowing assessment with a speech pathologist. And I do prefer a clinical swallowing assessment before some objective testing, and I'll go into why. So a speech pathologist and a clinical swallowing assessment, we're able to do that interview and try and figure out what exactly is going on, which may help us lead to recommending further testing. A modified barium swallow is completed in radiology under fluoroscopy with a radiologist and a speech-language pathologist. Almost like a movie, right? We get to see how everything is flowing. A fiber optic endoscopic evaluation of swallowing is completed in office by an otolaryngologist or a speech-language pathologist. And that's when we will thread a camera through the nose to get an aerial view of the vocal cords. See where things are, if they're headed towards the airway. We also get to view vocal fold motion, which is wonderful. There's a few options for assessing swallowing function. So after we have done a clinical assessment, we've talked about what could be happening, we figure out what objective testing we'd like to get. There are interventions for oral and pharyngeal dysphagia. There are a few. We may do some diet modifications. In general, soft, moist solids work best. The reason being is they stay together and they're easier to masticate. Avoiding cold items is key sometimes. A lot of my patients, I'll come in and sometimes I forget and I'll offer them a cold water and they say, no, I need room temperature because they don't want that feeling when the myotonia kicks in. And if chewing is very difficult, sometimes we talk about liquid supplements or even softer foods to make sure they're getting adequate amount of nutrition, which we will discuss further with Robin. Equipment and utensils. There's a lot of products out there which are great right now, but really to figure out if they work for the individual patient, it's good to work with a speech pathologist to figure that out. I have some that I will recommend some of the commercial slow flow cups to help out. And then sometimes I will just find a cup in the cupboard that works better. Usually a cup that has a lid with a slot, like a coffee cup, does wonders. It keeps the flow of the liquid in the center of the mouth. It slows the flow slightly, and it's also quite socially acceptable to walk around with a coffee cup. Maneuvers. This is a very specific thing that would be trained within clinic. We usually like to try them out within the clinical setting and then do them under fluoroscopy or with a fee study to see if they're working. So there's a few that may or may not work. There's a balance, though. Sometimes maneuvers can be fatiguing. So I always like, if the maneuver is working under fluoro, I'll say use it, but if you feel like you're getting tired, then don't worry about it. Let's tweak it another way. You know, one thing I really want everyone to take home from this is swallowing can change, and I think everyone who's going through it can understand that, but the speech and swallowing muscles, they're like other muscles, but they're a little different at times also. So you could have a time where you're eating just fine, and then you go to get that other item later in the day, and it's just not working for you. So really the recommendations and the strategies will vary, and I want you to have recommendations and strategies in a toolbox that you can pick and choose what you want to use throughout the day. Pacing and feeding techniques, small bites and small sips. I think that's a universal recommendation when there are any swallowing difficulties. The smaller the bite, the smaller the sip, the easier to control. Postural position techniques. Everyone's aware of the chin tuck. I think the chin tuck is great. It does not work for everyone. So again, it's one of those things that, you know, my days in the hospital, all my nurse colleagues, whom I love, would say, oh, just try that chin tuck. But it doesn't work all the time. So again, it's another intervention that a speech pathologist and the patient work together to see if it works for them. I also have some patients that will use a chin tuck when they're fatigued, and then when they're not fatigued, they don't need the chin tuck. So really, it's an evaluation, and it's a tool in our toolbox. Drinking in upright position. Use gravity as your friend. For leaning back, it's a little harder to control things. So always sitting at a table, upright position with good support for all of your muscles can help swallowing efficiency. And education and counseling on aspiration precautions. And this is a big one. At Penn, some of the neurologists will send me patients with myotonic dystrophy just to kind of do a checkup, which is great. Swallowing is awesome. A part of that evaluation is we want to talk about what to look out for in case it changes. And we want to intervene before things, you know, the biggest thing for me is sometimes I'll get patients later on and they're losing weight and it's difficult and they're frustrated and they're starting to get depressed because they can't eat the things that they wanted to eat. So this education and counseling piece is huge. If we get in early, we can really kind of tweak things and help quality of life with eating and swallowing. And counseling on alternative means of nutrition. Sometimes it's difficult to get everything you need through the mouth. And we will, a part of speech pathology, we will work with the patient. If it gets to be too difficult to get liquids and solids in, we will discuss in coordination with the medical team about counseling on alternative means of nutrition. So esophageal dysphagia is common in myotonic dystrophy. It really is diagnosed by a gastroenterologist or neurologist or primary care physician. We will get consults as a speech-language pathologist, mainly with reflux. They want us to kind of talk about different consistencies that may be helpful when you have this difficulty, and also counseling. So I want to touch on that a little bit before we end. So how speech pathologist helps with esophageal dysphagia would be to provide education and counseling on food and liquid modifications. Again, if things are getting stuck in this area and it's uncomfortable, liquids and soft solids might be a little bit easier to eat, and we'll talk about that. Education and counseling on lifestyle modifications. And I just listed a few just for general education. With reflux, if you are overweight, it is recommended that some weight loss, so we take some pressure off of those organs. Elevating the upper body when sleeping. So everyone says, oh, prop your head up. Not the head. We're going for the torso here. We want gravity to help prevent that reflux squeezing up. Reflux pillows a few years ago were really, really expensive. They're a lot more affordable now. They're a lot more comfortable. You can move around. So we will talk a little bit about elevating that head of bed. Also, what you'll read sometimes with general guidelines, they'll say, prop your bed up. Well, that's great, but sometimes you slide. So, sometimes it works, sometimes it doesn't. Avoid acid reflux-inducing foods. The main culprits generally out there, caffeine, chocolate, alcohol, peppermint, fatty foods. What I have found from patients' report is that, yes, these are culprits at times, but it doesn't aggravate people's reflux. So over the past few years, what I've been really recommending is try keeping a food journal. If you're having some difficulties, jot it down. Maybe we can track it together and figure out what's going to work and what's not going to work. Quitting smoking, avoiding late meals, going to bed on a full belly, there's just more stomach churning, more acid building. So if you try and cut back and maybe not eat, depending on the person, but usually an hour, sometimes 2 hours if you have some severe reflux. We'll talk about that too. And avoiding tight-fitting clothing. This makes a big difference. So loose-fitting clothing is usually more comfortable and may not squeeze those organs to cause reflux. So our take-home points, when in doubt, ask for an evaluation. Our goal as therapists, especially speech-language pathology, we really want to help your quality of life. We get very, very creative, and our therapy is truly individualized. We're in this together, and a big thing I will constantly say to my patients is that you are our team leader. I make the recommendations, but really if I need the patient to be on board for us to work together and do good things. So that concludes our talk with some resources, and thank you very much.
Okay, you all have been sitting for an hour or more, so would you like to stand up and stomp your feet for just about 10 seconds, and then sit down, and then we'll talk about nutrition. So everybody stand up and move. Stretch. We can have our physical therapist lead us in something. No, we won't quite go that far. Okay, so my name is Robin Meyers, and I am a pediatric dietitian. You can stand up if you want to. It's fine with me because I'm up here standing, so that's okay. I am a pediatric dietitian, and I realized a few days ago that I probably have never worked with adults. So I apologize to most of you in the room because I really had to kind of make a stretch to be able to do this talk today because I'm used to talking to children. So if I get a little bit juvenile, that's because that's what my population is. So, okay, so there's my apology in advance there. So, as I said, my name is Robin Meyers, and I work at the Children's Hospital of Philadelphia, and I'm lucky enough to work in our neuromuscular clinic where we have physical therapists. We're getting a speech therapist, not this particular one, but we're very excited about that. So my objectives for today are very, very general. I want to talk to you about the basics of a healthy diet. We're going to talk about what amounts of fiber and fluid are, and I'll talk to you about why those are important. We're going to talk more about the coping strategies for dysphagia that Leslie started on, and weight management. And weight management can either be if somebody's heavy or if someone's thin. So for me, it's both, okay? It's not necessary. You hear weight management, you think, oh, they're sending me to the dietitian because I need to lose weight. Not necessarily. All right, and then the last is, where do you go in your community to get good information, or where do you go on the internet, okay, to make sure that you're getting information that's reliable. I keep forgetting that I'm the one that's clicking this thing up here. Sorry about that. So basics for a healthy diet. The nutrition recommendations for myotonic dystrophy are not that different than anyone else on the planet.
all right? What we want you to do is increase your fruits and vegetables and lean meats, and we want you to limit sweets and sweetened beverages. And what I forgot up there were grains, okay? We want you to do whole grains. So the picture on the side there where it says choose my plate, that's one of my favorite pictures because that's what all of our plates should look like, all right? Not necessarily the same texture maybe or the same texture, but half of our plate should be fruits and vegetables and very colorful. And the other half should be grains and protein. And look at the protein, okay? Protein is less than a quarter of your plate. And then dairy should be included as well, all right? And I happen to like my plate a lot for good, basic, general nutrition information. It's a great place to go. So there are no special foods, magic foods, that are going to make any one of us healthier. It's really good, basic nutrition, lots of fruits and vegetables, lots of fiber, things like that. But there are special considerations, and you've heard some of them up here already, with Leslie talking about dysphagia and with Katy talking about exercise and movement. Boy, I'm clearing the room, man. What's going on? Okay, so let's talk a little bit more in detail about this. So we want you to increase your fruits and vegetables. Why? Because they are low calorie, they have high nutrient and fiber content. And those are very important things because we all know in this room that you can have problems with constipation with myotonic dystrophy. Your GI tract is a smooth muscle, and it may not work properly. So you need to make sure that you're getting adequate fiber and fluid to help with that situation. It also helps with weight management. Things that are high fiber but low calorie are going to fill you up and make you healthier. If you are underweight, then what I need you to do is take those high nutrient things like strawberries and dip them in chocolate. Take your apples, which are high in fiber and nutrient value, and dip them in peanut butter or caramel, because then you get the extra calories, but you get the vitamins and the minerals and the fiber and the nutrients from the fruits. And the same thing with vegetables. If you have a weight issue, you eat the vegetables. If you have the opposite weight issue where you need to gain weight, you dip it in some dip or some cheese or something like that, okay? But it's the same basic information for all of us. We want folks to eat more lean meats, things that are grilled and broiled and baked, and then with liquid, because if you have a chewing and a swallowing problem, the last thing you want is some piece of dry chicken on your plate. So we want it to be juicy and cut into small pieces. All right, so we're still getting started in our healthy diet. We want you to increase fluid, okay? Water is best because it fills you up and it helps with constipation. And one thing I want to warn you about is you can eat all the fiber in the world, and if you don't have enough fluid, it's not going to work very well for you, okay? Think of that sponge and your kitchen. Does everybody, I use a sponge to wash my dishes, and overnight it dries. A sponge is fiber. It's a hard rock piece of fiber when I get up in the morning. How do I get that? How do I use that? I put it under water and it expands, right? And then I can use it. And that's what fiber does in your GI tract. It can sit there, and if you don't have enough fluid to expand it, put pressure on the smooth muscle and make it go through, then you can actually have a lot of pain. So you need to have the fluid. You need to increase the whole grains, and those sugary drinks, juices, desserts, sports drinks. I have to tell you, I hate sports drinks. So please, if you want some flavored water, that's fine, but we don't need Gatorade, and we don't need, what's the other one? Powerade and Gatorade and all of those drinks, okay? I shouldn't say we, I should say me, but most people don't need those sugary things. And look how pretty they are, actually. It makes your plate look great. All right, so one of the reasons that we're talking about things like fiber and fluid and high nutrient value things like fruits and vegetables is because in myotonic dystrophy, you can either have a muscle, maybe not a muscle decrease, a mass decrease, but a decrease in strength. And you can have problems walking, you can have problems exercising, and this can lead to a weight gain. Folks who are older have problems, can develop issues with type 2 diabetes, so we really don't want extra weight on you, and you don't want extra weight that is going to impact on your ability to move. We have problems biting, chewing, and swallowing. One of the first things I ask people is, do you have problems biting, chewing, and swallowing? Can your child bite a sandwich? Can they chew it? Can they move it to the side of their mouth? And these are also things that Katy, I'm sure, talks about with her patients. So if you've got problems and you fatigue in the middle of a meal, then that, for me, is not a good thing. We have the issues with constipation, and then we have the issues with weight management, either underweight or overweight. And all of these things are related. I'm so glad I went last because they already set the stage. Because the exercise is good, getting an evaluation for your ability to bite, chew, and swallow are great things. And we can adjust the texture and the consistency of the foods and the fluids to make you healthier. Oh, wait, did I? Okay. Oh, I added this, so I'm sorry. My organization today is kind of lacking. So we are so used to having soda and sweet tea and lemonade and all of those things, and it's like, well, what do I drink instead of doing this? Water is best, flavored water. Milk. Anybody drink milk? Thank you. There's a few hands up there. Okay, I see my special friend back there. She raised her hand. Okay. So, bones and teeth are important through your lifespan if you're a child. For me, because I work with children, I'm concerned about children developing strong bones and teeth. So instead of soda, I want them drinking milk. If you're heavy, you drink the low-fat milk. If you're underweight, you drink the whole milk or the higher fat milk, and sometimes with stuff in it so that you can add more calories. Do we need sports drinks? No. I guess I already said that. You can tell that they annoy me. All right, so you'll hear some other biases as well, and you can take my biases with a grain of salt, but I'm going to tell you why I have these concerns. All right, so if we've got decreased activity, we really, working with someone like Katy, it's great to find an activity and something that you like. You need to be as active as possible. It helps with muscles, it helps with well-being, it helps with weight management, either overweight or underweight, and it helps with constipation. So I'm all for exercise, all right? It's really hard to see these slides. Okay. I'm losing it here, folks. Okay. Right. So the weight management, the overweight issues. We want you to be active. We want you to limit those sodas. I guess I'm being redundant here, so we're just going to move on from that slide. All right. So let's talk about facial weakness and throat and problems with dysphagia, because those are things that I see in my children. I have several children with congenital myotonic dystrophy, and we run the gamut between children who are able to take all of their calories by mouth and some who need help with gastrostomy tubes and things like that. So there are a couple of diets, dysphagia 1, 2, and 3, and Katy and I had this conversation, and she didn't mention it too much because apparently they're not out yet, or they're not being used?
They're out, but it's kind of facility specific.
Okay, all right. And we don't use them.
Yeah.
So we don't use them at CHOP. But they're basically 1, 2, and 3 are different stages of either chopped food all the way to pureed food, and thickened liquids all the way to liquids like a nectar thickened all the way to like a pudding type of liquid. So what I usually suggest for folks who are starting to have problems with biting, chewing, and swallowing is to look for foods that are naturally soft, okay? I do work with some teenagers, and the last thing they want to do is, be sitting there with ground meat on their plate or like little chopped up pieces of things. And so things like tuna salad, egg salad, ham salad, meatloaf with some gravy on it, things like that are soft, things that you can mash with the back of your fork. Cottage cheese. Does anybody eat cottage cheese anymore? I mean, it's great. It's a good source of protein, and it's soft. And it has calcium and vitamin D. So I'm always looking for like that extra added value in things. So, and then with some of those grains that we were talking about, it might be difficult to eat a piece of whole wheat bread or a roll or something, but there are grits, there's polenta, there's cereals that you can eat that are soft. I think I have orzo up there. There's quinoa. There are all kinds of things that you can get soft, put other foods in them to make them taste better. If you're having grits, you can have grits with some type of a protein food, things like that. So look for naturally soft things that are easy to control, but also things that are easy to bite and swallow. For fruits, looking at items like applesauce, watermelon, a mashed banana, soft berries, soft strawberries you can mash and put in your ice cream. Things like sweet potatoes. What else have I got up there? Anybody have a favorite thing that they eat that's easy, a vegetable? No? That they want to share? Okay. So, but you get the idea. It's like you don't have to like puree things or mash things or buy special food. You can just take the food that you get in the grocery store and alter it. Putting gravy on things helps. Putting broth on chicken or some other type of meat will also help as well to make things softer. So I have smoothies at the bottom, and I just say smoothies, right? That's another thing that I have a concern about. Smoothies are great, and they're very popular, but if you have a weight problem, meaning you're overweight, you have to be careful with how you make them, because a lot of things that go into smoothies are high calorie. So if you're underweight, they're great. It's a great way to get all your vegetables and fruits and dairy products and things all in one cup. It's a wonderful thing. And if you're having problems on a particular day and it's difficult for you to eat, then that's the way to go. But they're not necessarily things that you should have sitting with the rest of your meal if you have a weight issue. All right, so let's look a little bit more about, talk a little more about constipation. So fiber is a wonderful thing, and what is the recommendation for fiber? The easy answer is more, all right? I mean, I have on here like that adults should have 25 to 35 grams per day. A child should have about 19. Let's see, you guys can see the age groups there better. But you see that, and it's real easy if you've got something that's packaged to add that up. But what I would like for you to do is take a look at your own diet or go and speak with a dietitian and find out what you're eating, and then you add more. You add an extra serving at breakfast, or you add an extra serving at snack time, things like that, so that you can increase the fiber in your diet. And you want to go slow. If you're not a whole wheat person or a fiber person, you don't want to go from 0 to 35 in one day, because it's going to be really uncomfortable. So do things like add an extra slice of bread or some whole wheat cereal to your breakfast, and then maybe an extra fruit or vegetable to your dinner. Do it slowly. And fluids, the easy answer is more. So the general guideline I think that we can all use is the 8 to 10 glasses a day, and we're talking about 8-ounce glasses. So those 16-ounce bottles that people carry around, okay, if you can drink 4 of those in a day of water or the equivalent, that would be a wonderful thing, and that is going to help with constipation and with weight management, because the fluid and the fiber, remember, is going to fill you up. And if you have the opposite issue and you need to gain weight, really remember, you get to break the rules. So that if you're having potatoes, okay, you get to pile on the cheese and the butter and the sour cream, all right? If you're having sweet potatoes, same thing. Sweet potatoes are one of my favorites. Acorn squash. Acorn squash is something that's nice and soft, and you can add brown sugar, you can add butter, you can make it savory by adding sausage, ground sausage to it, things like that. So keep those things in mind. All right, so sometimes people need a little bit of help even after they've increased their activity. They've increased their fluid and they've increased their fiber, and we will often use stool softeners and polyethylene glycol. I'm not allowed to say what the product is because I'm not supporting anything, but that's the generic, and different types of stool softeners. So those are things that you can talk to your doctor about, because the last thing we want is for people to be uncomfortable and eat less. We don't want you to eat less. And managing the constipation is an important thing. So now I'm going to talk about smoothies. So a word about smoothies. Like I said, they're a great way to get everything in your diet. Protein, as I said, vegetables, fiber, all of that kind of stuff. But be careful, because if you're using ice cream or using whole milk or you're using cream, then you can really rack up the calories. If that's your goal, then that's great. But it's not an everyday thing unless you need the additional calories. So I would use them for special times, like if you're sick or you're not able to eat well, things like that. Or you're just tired and you really want to be able to get good nutritional value in an easy form. All right, there are commercial products. Lots of companies make them. There are lots of things out on the market. What I would suggest is looking for something that is a high protein but a lower calorie if you have a weight concern, and then you can make them yourself. But as I said about 14 times now, be careful what you make them with. If you're sweetening them with honey or sugar or ice cream, be very careful, because they can really pack a calorie punch. All right, so Leslie talked about, what did you call it? Alternate nutritional delivery systems. Okay. So we have several children that can eat by mouth, but they can't eat enough. They tire out. Children have the extra added concern of needing to grow. Adults, we're done. We just need to maintain our weight either up or down. And children need to continue to grow, and sometimes it's very difficult for them to get everything in by mouth when they have weak throat and jaw muscles. So we usually look and work with the families and work with a speech therapist and make sure people are safe to eat. If you're not safe to eat, to swallow because of aspiration that Leslie was talking about, either from the top or the bottom. The reflux is what we call the bottom, and the food going down from the top. Then someone will probably talk to you about either a gastrostomy tube or a nasogastric tube. And an NG tube is a short-term solution. We usually only use that for a few months, and if we have children or young adults, or anyone that needs that support long term, then we usually go for a gastric tube. And the interesting thing about a G-tube is that you can use it as much or as little as you need it. We have folks who, I have, for every child that I work with that has a gastrostomy tube, I have that many different schedules and ways to feed them. Some children are totally tube fed, some children eat because they're safe, and they eat what they feel like, and then the rest goes down their tube. And I have folks who only use their tube when they're sick. I have people who can eat, but they can't drink, and so the fluids go down their gastrostomy tube, or their medications go down their gastrostomy tube. So they're really, for us in the pediatric world, they're just like one more modality that we can use to pull out and help children grow and be healthy. And I'm not sure that they're viewed that way in the adult world. So it's, what I'd like folks to remember, to take away, is that this is just something that can help you remain healthy. All right, so where do you go in the community to get help? I know in the pediatric world there are lots of dietitians. In the adult world, I don't think that there are as many. Just to give you an example, at Children's Hospital, we're about a 600-bed hospital, and we have 90 dietitians. I don't think they have that many at Penn. No. So you can get help in the pediatric world. So what I suggest is that when you're looking around and you need help with a dietitian, that you make sure you find someone who is a registered dietitian nutritionist. And I used myself on here. You can see like all the initials after my name. So the MPH means I have a master's degree. The RDN means I'm a registered dietitian nutritionist, and all hospitals hire registered dietitian nutritionist. We all have a similar educational background, we've done an internship, and we've passed an examination, and we do continuing education. So, and then the LDN at the end is I'm a licensed dietitian nutritionist, and licensure across the country is not the same. Every state has their different rules, and Pennsylvania, New Jersey, and Delaware happen to have licensure. There are, I think, maybe 15 or 20 states that don't. But anyone can call themselves a nutritionist, but only certain people can call themselves a registered dietitian nutritionist. So those are the folks that you really want to look for. Where do you find them? You find them at the American Academy of Nutrition and Dietetics. I forgot to put it on here. It's a very easy website to remember. It's called eatright.org. Okay, so if you're ready, if you're looking for a dietitian, type in eatright.org and you'll get to the American Academy of Nutrition and Dietetics, and they have a dietitian locator in your area, or go to your local hospital and see if they have an outpatient dietitian. And those are the folks that I would suggest that you talk to in terms of finding a good program for you. Some reliable information, again, the Nutrition Academy for Nutrition and Dietetics. I hesitate when I say that because I'm old, and we were always called the ADA, the American Dietetic Association, so when I have to say something different, it's hard for me. So we're the Academy now. The Myotonic Dystrophy Foundation website is a good site. USDA is a good site. There are others, like Mayo Clinic is a good site. Like, so that if you're just Googling a question, and some of the university hospitals and teaching hospitals come up, those are the sites to go to. NIH is a good site to go to for any type of information, not just nutrition information. So, wrapping it up, we talked a little bit about the basics of a healthy diet. They're pretty much similar to the rest of the population. We talked about fiber and water. It's basically more and more, okay? For adults, it's 25 to 35 grams of fiber and about 8 to 10 8-ounce cups of fluid. Suggestions for weight management: increase fluid, increased fiber, increased grains, increased activity, decreased sugar, anything that's sugary, desserts, sweets, sugared beverages, and where to go for good nutrition information. So thank you for listening, and take care, everybody. So I guess we're gonna have questions? So, okay.
Is there a microphone going around in the audience to be able to ask questions? Or are they cards?
Uh-oh.
Do you have a mic? Yeah.
Oh, that doesn't come off, okay. You're gonna have to stand up and shout really loud. So the gentleman with his hand up.
Yeah, so I'm asking this for someone else, so I'll speak the first person for him. You're right, I have difficulty keeping on weight and retaining muscle, and I have muscle wasting. I have a two-part question. Some of this I think you've addressed already, but in terms of aerobic exercise, how do I get my aerobic needs met without resulting in weight loss? Because he's on that side of things. The second part is in terms of diet. What do you recommend for putting on weight in a healthy way? I think you've addressed some of that already with the dips. I have a sensitivity to dairy and gluten. So those are the two questions.
Okay. So I'm going to let Katy talk about the aerobic stuff, but actually the take-home for people who need to gain weight is you get to break the nutrition rules. All right? Seriously, that's pretty much the bottom line. So I still want you to eat grains and fruits and vegetables, and as you said, dips, or if you're eating cereal, or if you're eating bread, you're going to put something on it. You're not going to eat anything plain. And you are the crowd that can have smoothies and milkshakes. And there are a lot of commercial products out there that you can use as well. There was something else about nutrition. Oh, the gluten. So a lot of the commercial products that you could use as a base for like a smoothie or a milkshake are gluten-free. So I'm going to go out on a limb and name some of that. Ensure, Pediasure, those kinds of things, those are gluten-free. They are not, they're lactose-free, but they are not dairy-free. So if your friend has a problem with dairy, that would be difficult. There are some juices as well, Boost Breeze. I'm not supposed to name names, but there are some juice drinks as well that are high calorie, high protein. So you can add those. Muscle bulking, what you really need to do is protein. So the job of protein in your body is to maintain and repair the muscle that you have, but it can also be burned as energy. And protein is the only thing that can preserve and repair muscle. So you have to have an adequate diet of fat and carbohydrate for energy, and then at least adequate, not necessarily extra protein, but enough protein so that you can spare that protein for tissue growth and repair and not for energy. So, and I'll let you talk about the exercise part.
I think, is this on? Yes, so I think just the additional piece that I would add is just when you are doing aerobic exercise for all the other health benefits, you can create a calorie deficit. So you just need to make sure that you consume more calories on those days that you're doing aerobic activity to make up for the loss.
I have a question about insurance and physical therapy. So physical therapy, are you limited, even though you have a myotonic dystrophy condition, are you limited on the number of times you get that insurance will cover?
So it definitely varies by insurance plan. So there's not a standard that goes across all plans. I think something that I would say is that physical therapy has to be goal-oriented. So it needs to have specific goals. So you wouldn't necessarily see a physical therapist for 300, for an entire year typically. You'd have a evaluation, and then have a plan of care that you would seek an episode of physical therapy for. And that could be 3 visits, it could be 16 visits, it's whatever the therapist and you feel that is necessary to meet those goals. And then you may take a break for physical therapy and have a home exercise plan to carry out and continue with. And then maybe in another year, then you reconsult with a physical therapist because your condition has changed a little bit. So it's really, physical therapists are often working in more of episodes of care versus long-term care, if that makes sense. And typically an insurance plan will cover so many visits a calendar year. Sometimes if there's injury, like a very traumatic fracture or something like that that's going to take an additional healing, sometimes you can submit an appeal to the insurance company to request more visits, but it's not always something that can be done. So the therapist will work with the patient to kind of make sure the coverage extends to what they need.
I have 2 questions. One's for Leslie. Sometimes I wake up in the middle of the night with the mucus stuck in my throat, and I can't swallow it down. So I read on the Facebook pages that some people use Mucinex every day to help thin out the secretions. Is that safe?
I would consult with your physician. I have heard it being used, but you want to figure out what's going on, why you're having that coughing, so I would mention it to your doctor.
It's
And
not really coughing, it's just like a stuck,
yeah.
ball.
Yeah, I would mention it to your doctor, definitely. You can try elevating. Are you elevating at nighttime?
No.
You can try that and see if that helps. But I always say you should probably talk to your physician and see if that may help.
All right, thank you. And Katie, would vestibular therapy help with balance, even though you have weakened leg muscles? Like, is it worth trying vestibular therapy?
So it's probably worth having somebody evaluate your vestibular system if you think that there's a reason for your vestibular system to not be working properly. If there is vestibular loss or vestibular hypofunction, then it can be improved with therapy. Even in the situation where there is still muscle weakness and those reactions may be limited, it may make you feel more balanced, probably more than anything, but definitely an evaluation for it.
A comment first. I have the balance issues and I did the physical therapy. I'm doing it right now, the exercises, and it is helping. Good. Okay.
Great.
But my question is on speech, okay? And my neurologist seems to think that a medication, a muscle relaxer, would help. I can't tolerate muscle relaxers. They just put me to sleep. They make me feel like I have like the worst hangover ever. It just doesn't work for me. So outside of medications, okay, and I have, the speech problems right here, and it seems to be worse when I exercise. You mentioned cold water today, and all I drink is water, so that's something. Is there anything I could do? It does impact me. It impacts my job. I mean, I speak for my job, and it's going to, hurt me. So I just wanted to hear your feeling. And I am in the Philadelphia area too, so I'm particularly interested in hearing your opinion.
Great. You can come see me. I think it's very personalized. So have you ever had a speech evaluation? Have you worked with a speech pathologist? Okay. So I usually recommend the evaluation and talking with the speech pathologist to see, all right, what can we try? It may be like I said, it may be exercises, it may be compensatory strategies, it may be more work-related types of things. But we do get really creative within our therapy sessions, and it's really not cookie cutter. And I wish I had so I definitely think if it is something bothering you, then I would request a script for a speech pathology evaluation, and I can help you find someone to go to close to your home, or I can give you information about our clinic at Penn. Mm-hmm. Right, and that is a part of the therapy also, is that we do the evaluation, figure out what's happening, and guide you as to, do we think that therapy is going to help, or is it more strategy training and that counseling piece? And I think that's a big thing too. Sometimes I find physicians are a little resistant to refer for speech therapy because like, well, there's no exercises that work. Yes and no. It depends on what's causing the speech issues. But there's more to therapy than just exercise. There's this whole other behavioral component that I'm finding is actually the feedback I get from my patients is that that's really helpful. So I would take it from that standpoint. You're welcome.
Leslie, my son is 2.5, going to a speech therapist, and she is struggling to find specific information about myotonic to help him. Do you have suggestions? She had never heard of it before she started with Patrick.
I'm sure we can get her some resources. I do not personally work with the pediatric population, but I can definitely help find some resources, I'm sure, with my buddy Robin over here.
Okay.
Absolutely.
I think milk and water are really the best things, especially, endurance athletes actually, and maybe Katy knows a little bit more, there are all these really fancy things that you can pay a lot of money for, but actually chocolate milk is a really good thing after a bout of exercise because it has the right amount of protein, it has calcium, it has potassium, it has carbohydrate, and it's a good rehydration fluid. So, was your question, is there something else that I would suggest besides the sports drinks? No, because they really just sort of like take the place of other things, in my experience, especially with kids. I mean, that you're not getting milk and you're not getting, the vitamins and nutrients. It really doesn't have value, the sports drinks. Yeah, but there are lots of flavored waters that don't have the calories and the sugar. Yeah.
This is a possible question probably for Katy, but with so much apathy and depression, how can you make somebody, I like your clothes on the floor idea for exercising. How can you make somebody get the motivation to want to exercise?
So certainly it can be a challenge, and I think, again, that's pretty individualized. So what works for one person may not work for another person. Potentially working with a therapist to get started, and having that, weekly appointment or twice a week appointment to start getting into exercise and developing a plan can definitely be helpful. And I think as a therapist, we would work with an individual to find out what their needs are, what their interests are, and really help to develop that lifelong plan. But sometimes sustaining it even after the physical therapist is finished is somewhat challenging. Sometimes using a trainer at a gym or exercise classes. I think really it's some way to create some accountability and some sort of schedule that can help, but certainly understand those are some of the issues that we deal with individuals with myotonic dystrophy. And it's talking with your physician and your medical team, whether or not there's other treatments to work with those specific symptoms, and really having a team approach to trying to get there. Because I think we're really finding out that it's important.
Hi, my question is about nutrition. I have a son, 7 years old. He has congenital myotonic dystrophy, and we are trying for him to lose weight. How do you have any suggestions to introduce him to new foods? Like he only eats bananas, no other fruit. And how can we make him eat vegetables? And he eats the same thing over every day. Is either rice and beans because we're from Puerto Rico, or sandwiches.
Yeah.
sandwiches,
So
a
that's
lot
the-
of bread, a lot of carbs.
Right, right. So that's the age-old question. It's a really tough one, and I think that it would be great for you to go and see a dietitian, not advertising, but really making sure that there's structure in the meal time, so that there's breakfast, lunch, and dinner. That there's not a lot of snacking in between, and snacking, and I have nothing against snacking. I think snacking is wonderful, but you have to schedule it just like everything else, because a young child will come to the table and not be hungry if you allow them to eat and drink randomly between breakfast and lunch and dinner. So one of the things that you want to do is have them come hungry to the table, and always offer a variety of things. It takes young children 10 to 12 tries to sometimes accept a new food. So it's not a one and done. You can't put the broccoli on the plate and say, well, they didn't like it once, and so that's done. So it's not an easy situation, but structuring meals and repeatedly offering the food and letting your children see you eat those foods. So we all have to take a look at our own diets when we're talking about our children, because a lot of times, it's like, Dad doesn't eat any vegetables, so Mom doesn't cook any vegetables, so Johnny doesn't eat any vegetables. So it's a challenge. There's a lovely book called How to Get Your Kid to Eat, but Not Too Much. And it's by a woman named Ellen, Ellyn Satter, Satter. And it's a lovely book. I recommend it for anybody. It's like a parenting surrounding food type of book. So hopefully that will help you.
My questions are for Robin, nutrition. So my 7-year-old with congenital myotonic dystrophy, okay, eats small amounts, so I've got him 6 meals. And we eat vegetables, and often I'll take a piece of my vegetable from my plate and put it on his. It's generally the last thing he eats, but we don't leave the table till he's finished. So he's doing better on that, but not very much. So I give him those little squeezy things. Tell me, Robin, yes or no? He can have one a day. Because he will suck that stuff down.
Do the adults in the room know what she's talking about? Like those little, yeah.
The squeezy, yeah.
So I have mixed feelings about those squeezy things. So developmentally, it's not doing anything. It's, but if it's
just nutrition.
Right, exactly. But if it's something, if he's having issues with biting, chewing, and swallowing, then maybe those little squeezy things aren't so bad. And I would take a look at the nutrient value of them. I think I would use them sparingly, but keep doing what you're doing.
I do one a
Exposing
day.
him-
Okay, one a day, he gets it.
Yeah. Keep offering him the new food. And seriously, my favorite book on nutrition and parenting is the one that I just said. She goes through the lifespan of food and parents and children, and it's really a good one.
To get him to eat green beans, I put a little bit of cranberry.
Oh, there you go.
And now I don't have to do that anymore.
There you see? Yeah.
Okay,
yeah.
so for me, we are 3 generations with DM. And I decided, okay, I'm going to get pay for swimming for my daughter and I, because she won't do it by herself. She's more affected. And I thought, well, if I take her and I'm going, maybe we can get that going. So I appreciated that. But the swallowing is, I get tired, the eating. So I've started with Herbalife shakes in the morning and for lunch. Mm-hmm. It's better for me. And you don't have to say anything about the product, but am I doing something that's nutritionally okay?
They're probably nutritionally okay, but they're outrageously expensive. You can probably make something yourself or get something
The time
off a
is the
shelf.
issue because I've got the 7-year-old with the
Yeah,
congenital.
sure.
I got a 35-year-old with
Yeah.
and I don't have the time.
I don't know a lot about the Herbalife products, but I do know that they're very expensive.
Yeah, but nutrition. So you don't know any nutrition. You're not going to say, "Oh my God,
I'm not
don't
good.
eat
I
that."
don't know the nutrient value.
Okay.
Yeah.
Then that's
sorry.
fine. That's
Sorry.
fine. And then I also need some kind of referral from my speech therapist for my child because, and I'm in California, they don't know what to do with him. Now, he's going to a speech therapist.
Come see Leslie later.
Okay, thank you. Thank you.
No.
I don't know.
We probably have time for one more question. And then everybody should have green cards on their table or a neighboring table. And if we didn't get to your question today, this morning, we'll have time this afternoon.
You want to go?
Is there any evidence supporting selenium, CoQ10, vitamin E, or those IV drips for hydration?
And what for hydration? I'm sorry.
Do you ever hear of the IV drips? It's all over New York City. They're like little bars where you go for an IV and they give you vitamins or water.
You know what? That would be really hard for me to speak to those things. My first reaction would be probably not. There's not a lot of evidence, but I really can't say.
And how about the selenium, CoQ10, vitamin E?
Specifically in myotonic dystrophy, no. But I have had other folks using the CoQ10 and things like that for other neuromuscular disorders, and it seems to help. But that is something that I don't know a lot about. I apologize.
Okay, thanks.
Hi, one thing, I know that you're done with questions, but my daughter none of my daughter who has children doesn't have myotonic, but only based on the squeezy things that you were talking about, because she gives it to them on a general basis. She gives them this happy family thing, and it looks like a very interesting, healthy product.
Yeah,
If you
I would really just make sure you check the label of
yeah.
things and make sure they're not.
It's up to you
have
for
a
the
lot
label,
of
but this is
added-
what it is.
Added
If you want to read the
things.
label.
So, yeah. Yeah, I mean, it's probably like a piece of, an apple, except it's minus the fiber. Yeah. Yeah. So, but just remember though that it's really hard sometimes to get. There you go. Okay. So it does have fiber in there, folks. But yeah, so I would really look at the label of things, and if there's extra added sugar or if there is no fiber. I mean, that's the problem with juices, is that you can get vitamin C, but you don't really get anything else. You get lots and lots of calories, and you get a little bit of vitamin C, and you can get the same thing from an orange, and then you can get some fiber with the orange. So thank you, folks.
Let's thank our speakers for a great session. And lunch is going to be back in this room, and they're setting up table signs if you want to sit with people from your geographic area. So thank you. Thank you again.